So what you're looking at right here is going to be the inside of a scalp. Now watch as I lift this towards the light, you're going to see that some of the light is peeking through the tissue. That's because you're looking at the inside of a scar. You see, scars are just a bunch of collagen fibers kind of scattered and stitching together two ends of the wounded tissue to try and bridge that gap. And then over time, it slowly starts to contract and shrink. That's why you may have noticed on your own body, when you look at scars, over time, they slowly get smaller and smaller and smaller. Okay, so what you're looking at here is going to be a cross-section of a human thigh. You can see the femur, we can see the anterior thigh compartment, posterior thigh compartment, medial thigh compartment, and up top here you can even see the skin. So this is going to be the epidermis that I'm poking, but if I kind of flip this up, you can see that there's this other piece of tissue right here between my fingers. We call this the fascia lata, and the fascia lata just means broad piece of fascia, but what it's going to be doing is surrounding and helping to compartmentalize the muscles of the thigh. So the fascia lata is going to help and assist in creating that anterior thigh compartment as well as that medial and posterior thigh compartment. So when you hear people talk about fascia, well, at least the fascia of the thigh, they're really probably talking about this right here called the fascia lata. So I want to show you just how mobile your sternoclavicular joint actually is. So using one of your hands, you're going to place it on the opposite side's clavicle, and then you're going to raise your hand like this. And as you do that, you're going to feel that clavicle go up. That's elevation. Bringing it back down, you can feel it going down. That's depression. Pushing in front of you is going to be protraction, and then bringing it back is going to be retraction. But here's the real kicker. If you go ahead and spin your shoulder like this, you can feel that clavicle rotating even as you bring it back. And that's because your sternoclavicular joint has 3 degrees of freedom, meaning that it rotates or moves in all 3 dimensions of space. Now, we also need to be aware that it can be very challenging at times to heal a clavicular fracture. So if you pretend that your arm's in a sling and you once again place your hand on your clavicle, if you do all these little minor movements of the shoulder, you can feel that clavicle moving around. So say like you're bouncing in a car, or maybe you're just doing day-to-day life. That can make it extremely challenging at times for a clavicular fracture to heal. So what you're looking at here is going to be the front of the thigh, so we can see the quadricep muscles as they are turning into this massive tissue here called the quadriceps tendon, which is then going to turn into the patella, or your kneecap, which then turns into the patellar ligament, this soft piece of tissue here, which is then going to connect to your tibia. So when the quadriceps muscles contract, it's going to pull on all this connective tissue and that patella, causing the knee to come forward into knee extension. But if you've ever had a healthcare provider hit this patellar ligament with a hammer, it causes the quadriceps to contract, kicking the knee forward. That's because you've initiated a patellar or stretch reflex. See, when you hit those fibers, it causes a kind of tugging, which will then relay to these muscles. And when you tug on the muscles too quickly, inside of them are sensory receptors designed to protect it from being stretched too quickly. So a sensory neuron goes to the spinal cord and right back out to the muscle, causing the muscle to contract and kick away from the stimulus, protecting the muscle. A lot of times my students will ask me, hey, Justin, did somebody break the femur? There's like this indentation here on the head. And the answer is no, that is normal. This is a bony landmark called the Fovea Capitus. And this indentation is where a ligament called the ligamentum teres attaches. So you can kind of think of like this wire of sorts coming out. And what it would do is it would insert in this socket area called the acetabulum, just anchoring and helping to secure your hip joint. So no, this little thing right here is not a indentation or like someone chipped the bone. That is normal. All right, so I want to take a look in this lower portion of the leg at this bone here called the tibia, and the fact that if you look really closely, there's something on top of the tibia. Now, we've cut a little window inside so you can see that the bone is hollow on the inside, but our focus wants to be on this tissue right here that's on top of the compact bone of the tibia. You see, all of this is called periosteum. Periosteum literally means around the bone, and this is a tissue that's loaded with bone cells and nerve endings that surrounds all of your bone. So here's a kind of cool fact. When you break a bone, the bone itself isn't really processing the pain because there's no real room for nerve endings inside of bone tissue. Instead, when you break a bone, you're tearing this tissue here, that periosteum, which is loaded with nerve endings, and that's sending a bunch of pain to your brain, letting you know that you've just had a pretty intense injury. The job of skeletal muscle tissue is to contract. So if it is to contract, you can kind of picture these muscle cells just bunching up like that. We call that a concentric muscle contraction. But if all of these muscle cells were to contract and get longer, we'd call that an eccentric muscle contraction. And on top of it, they can even contract and stay the exact same length, and we call that an isometric contraction. So here, I can give you a quick example. If I look at my arm here, let's say I contract my biceps and I cause my elbow to flex. Well, what happened is my biceps muscle got shorter, bringing my elbow into flexion. That's a concentric contraction. But let's say I was lowering something down, my biceps is still contracting to kind of guide that motion. We call that an eccentric contraction. And then if I just held my arm out like this, no movement is being generated at the joint, but my biceps is desperately holding on to keep it stable. We call that an isometric contraction.
So the other day in the clinic, I had a really interesting case. Mom brings in her 5-year-old daughter and 8-year-old son and says they have a red, bumpy, itchy rash, and she didn't know what it was. Now, when I looked at the rash, this isn't a rash you see very often in the clinics anymore. But then she said, hey, Dad also has a rash that doesn't look totally the same, but was wondering if it was related. So she showed me a picture of this rash, and this is what it looked like. That's a shingles rash. Now, one, how does that relate to the kids? And what type of rash do you think they actually had? And two, why don't you see the type of rash that they had very often anymore in the clinical setting? I want to know what you guys think. So go ahead and post some questions and comments below. We'll address all that in the next follow-up video with the exact details of these different types of rashes.
Let's quickly talk about the differences between a mole and a freckle. You see, moles are going to be groups of melanocytes or pigment-producing cells, and as they're grouped together and producing their pigment, you get these darkened, raised, bumpy areas. While freckles, on the other hand, are typically a response to sunlight. So you have the same amount of melanocytes in this freckled area as you do right next to it in this non-freckled area. The difference is these melanocytes are producing a darker pigment, or at least more of the pigment, so you get a freckle. These can also be temporary, while these are typically permanent.
So the other day we did a video on a rash that 2 of my patients had. So if you missed that, hurry and jump over to it because this will make more sense after you've seen that. We said or saw that Dad had a shingles rash, and I asked, what type of rash did the kids end up with? And a lot of you commented and said they had the chickenpox rash. That is correct. Chickenpox and shingles are both caused by the varicella zoster virus. The primary infection with that virus is the varicella rash, which we nicknamed chickenpox. The secondary or latent infection that can reactivate later in life is called the herpes zoster rash or the shingles rash. People also commented that the kids probably weren't vaccinated. They actually were vaccinated. They had 1 dose of the vaccine. 2 doses is more effective. But often people who get vaccinated, 80% of those people will never get the infection or manifestations of the infection. Those that do tend to have more of a mild case, which was the case with these 2 kids that I saw in the clinic.
So this structure right here, which is probably a lot bigger than you would think it'd be, is called the spleen. Now, one thing that I want you to know about the spleen is it is an actual reservoir for blood. It helps store a lot of your blood. And that's why if this ruptures, you can bleed out and die very, very quickly. I'm about to blow your minds, and you can do this along with me. So all you have to do is stick out your hand and close your eyes, and then boom, you can hit your hand dead center every time. In fact, you can close your eyes, hit your nose, hit your ears, your mouth, your elbow, your knees. You can hit pretty much anywhere on your body, and that's because you have what's called proprioception, which is your body's ability to detect where you are in 3-dimensional space. You see, inside of your tissues, like your joints, your muscles, and tendons, you have sensory neurons sending information to your brain, telling it the exact location and speed with which it's moving. So for instance, when my biceps contracts, a sensory neuron sends a signal to my brain saying, hey, we're getting shorter, that must mean the elbow is flexing. When you add that up across all the different muscles as you're moving around through your environment, that's how your brain knows where you are at all times. And again, we call that proprioception.
Dislocated fingers. They happen. Just had a patient with one the other day. Let's look at the relevant anatomy and then watch me pop it back into place. So these are the bones of your digits or your fingers. Each finger, except for the thumb, has 3 individual bones. The name of each bone is called a phalanx or a phalange. In between is called an interphalangeal joint. Inter just means between. So this is the proximal interphalangeal joint because proximal means closer. This is the distal interphalangeal joint because distal means further. It's a dislocated PIP joint, inner middle finger here, dorsal dislocation where the middle phalanx is on top of the proximal phalanx. So what we're going to do is just provide some traction, some hyperextension. And that was really easy, actually.
I still prefer.
Bend your finger for me.
Woohoo! I still prefer the shot.
Your large intestine, which is going to begin right here in an area called the cecum, and then come up and around into the ascending colon and transverse colon. Again, you can kind of see it coming all the way around here, and then it's going to dip down and it's going to disappear, but it comes back around and out right here as the sigmoid colon and like this. But the thing to actually understand about this is that all of that is made of what's called smooth muscle, meaning that it's involuntary. You do not have to think about moving the feces that is inside of your large intestine around. Well, until you get to the rectum, which is going to be right here. All of this is going to be the rectum, and this is made of skeletal muscle, meaning that it's voluntary. And I personally think that's a pretty good design because that means you are in charge of when you get rid of feces. And again, that just seems like a good idea to me. Okay, so there's a lot to focus on here. So I want to first orient you to this being the brain stem. We can see the upper portion of the cervical spine. This hollow space here is called the sphenoidal sinus, but I want to bring our focus to these two areas, one being the hypothalamus and the second one being the pituitary gland. Now, most people have heard of this pituitary gland, at least passively before, but the hypothalamus can be a new structure for a lot of people. So it's going to be located just about right here. Now, the hypothalamus, you can think as being more or less in charge or regulating this pituitary gland. The hypothalamus is sensitive to a variety of stimuli, including smells, hormones in the blood, and even light. And what it can do is give instructions to this pituitary gland to release hormones, which can then go and affect other endocrine glands like the ovaries, the testes, even your adrenal glands and your thyroid. So these two work in very close proximity to one another. In fact, we call that the hypothalamic pituitary axis. So this right here is going to be the proximal end of the femur, and this is a normal looking and normal functioning proximal end. You see this rounded portion? That's called the head. Then we have the neck, which goes around and that turns into this bumpy thing on the side called the greater trochanter. Now the femur is going to plug into this socket-like landmark up here called the acetabulum. But when I say normal looking and normal functioning, what I mean is that this angle is at around 125 degrees. But it can also have variability where it could be less, and it could be more horizontal at about 105 degrees or more vertical and be at about 140 degrees. And what that would do is put unnatural stresses on the joint itself, which can make the person susceptible to dislocations and even joint degeneration. Some of you have probably heard that we as humans have opposable thumbs. So I want to show you what that means. So if you kind of have your hand right here, you can actually oppose every single one of your digits. So what's happening here is you're swinging your thumb like this in order to meet the other digits. And that's performed by a muscle down here in your thenar or thumb pad called opponens pollicis. But what this opposition does is it allows you to grip things very efficiently. Now, if I moved my thumb to the side like this, I could still kind of grip stuff, but you can see that it's not going to be as advantageous as if I could clamp down on it with my thumb. So what this opposition of our thumb gives us is it makes it so it's extremely useful to not only grip, but manipulate things with our hands, which comes in very handy when we are creating and using tools. When it comes to the shape of bones, you have about 4 different types. So if we come here to the wrist, you're going to see these tiny little bones here. These are carpal bones, but they are an example of short bones, and they look just like little pebbles or rocks you'd find in a stream. Next, we have long bones, such as the radius and ulna, which you find here in the forearm, but that also includes the humerus, as well as that really long femur right there. But it also includes these long bones in the hand, deep to your palm, and the digits themselves. Those are classified as long bones. We then have flat bones, which you can find here in the ribs, your sternum, and you even find it up here in the cranial bones. And then we have irregular shaped bones, which are going to be like these vertebrae. And if you look at them, they just are oddly shaped. It's not easy to define as to the exact shape that they take, which is why we just say irregular. But these 4 shapes make up the entirety of your skeleton. Let's talk about how not every aspect of your heart is going to be as strong as other places. So if we look over here, you are looking at the thickness, or I guess you could say thinness, of the right ventricle. So what you need to understand about the right ventricle is this structure here that I'm opening up. This is going to pump blood to your lungs. And the lungs are going to be right next door to the heart. So it makes sense that you don't need an obscenely strong muscle to pump the blood right next door. But if we compare that to the left ventricular wall, look at how thick this is. And that's because the left ventricle has to pump the blood to the entire body through your arterial network. So it makes sense that you'd have a much stronger left ventricle than you would a right ventricle. I want to show you a unique relationship that this muscle right here, called the semitendinosus, has with the muscle just deep to it called semimembranosus. I can go ahead and grab tendinosus and just pull it to the side, and there is a groove right here that tendinosus fits into. So you can see this a little bit better if I come to this side and grab it, move it, you can see that little shallow indentation that tendinosus is going to slip right into. And so when I grab it like this, it almost to me feels like it could be one muscle, yet they are most definitely two. But they are actually belonging to a bigger group, which includes this one over here called the Biceps Femoris, and all three of them form the posterior thigh muscle group known as the hamstrings. Okay, so what you're looking at right here is the top of a real human skull, but what I want you to focus on are all these squiggly lines that you can see. We call these sutures, and these are joints that connect the different bones of the cranium. So we have the parietal bone being connected to the frontal bone, or the two parietal bones being connected to one another. Now, if you look at their shape, so what you can see right going along that, where that frontal bone is meeting the parietal bone, we call that a serrate suture, right? That right there. Serrate just means it's jagged, like a serrated edge. But if we look at this one running down the center, this is called a denticulate suture. Denticulate means tooth-like projection. So someone looked at that long ago and decided that those looked like little teeth. If you've ever had someone draw your blood, they likely targeted this vein right here called the median cubital vein. There are a few other options that they could have targeted, but this is the most targeted simply from an ease of access standpoint. But what they'll do is they'll apply pressure around the entire arm, which will prevent the blood from getting back to the heart, so the veins start to bulge and get bigger, and then they can feel that vein, and then they can target it with the needle and draw the blood. The terms anterior and posterior tilt are really popular these days in the fitness and bodywork realms. And depending on who you're talking to, you might hear that it's really important and bad for joint and low back health, or you might hear that it really isn't a factor at all and it's something you shouldn't worry about. Regardless, what they're talking about are these bones right here called the os coxae, and in which direction they are tilting in relation to a neutral position. So this point right here is called the anterior superior iliac spine, or the ASIS. Now, if this is tipping forward, we call that anterior tilt. If it's tipping backward, we call that posterior tilt. And again, that's in relation to a neutral position. So as the theory goes, if you have anterior posterior tilt, that can put unnecessary stresses on the joint and the tendons, ligaments, and muscles, and possibly even the intervertebral discs, which could potentially lead to a bulging or herniation. Again, though, there's still a lot of debate out there about this. A tendon like this one, which is the Achilles tendon, is a continuation of the connective tissue that wrap the individual muscle cells inside of the muscle belly. See, the muscle belly is this red portion that is also the contractile portion, while tendon is going to be nothing but collagen fibers. So what happens is all of these collagen fibers are wrapping these individual muscle cells, and then as soon as that muscle belly ends, the collagen continues on. And that's what we see as the tendon. And then that, I mean, obviously we've cut it here, but this would then connect to the bone. So what happens as these muscles contract, it has no choice but to kind of tug on the surrounding connective tissue, which then tugs on the tendon, which would then tug on the bone, and you've generated movement. Muscles do not flex. You see, flexion is an action at a joint. Like here, this is the elbow. So watch this. As I move the arm into this position, that is called flexion of the elbow, and that action is performed by this muscle here called biceps brachii and a couple others. But the muscle itself only contracted. You see, that's what muscles do. They contract. They don't flex. They contract to cause an action at a joint. You see, on the opposite side, we can see some of the triceps brachii here. Triceps, so if I brought the elbow back into this position, when triceps contracts, it's going to bring the elbow back into extension. So I can't say that the triceps flexed because it extended. So instead of saying flex your arms or flex your biceps, you really should be saying contract your biceps. Do you see these squiggly lines here? These are called sutures, and these sutures are joints that connect the different cranial bones together, like the occipital bone and the two parietals back here. But what I want you to focus on are these little islands that we can see of bone here. These are extra bones called Wormian bones, and they're not found in every cadaver or every skull, but they just kind of form within the connective tissue because originally these bones weren't united. If any of you have ever felt a newborn's head, you're going to feel these soft spots called fontanelles right here. So what can happen at times when the cranial bones finally do fuse, these little islands can start to form, and again, we call those Wormian bones. I want to show you just how layered your body is. So you're looking at the back. Now what we've removed is going to be the trapezius muscle, which would rest just like this. And we've also removed the entire right upper limb. But musculature-wise, if you look at this right side, you'll notice a difference from it and the left side. And that's because we've removed the latissimus dorsi on this right side. We've also removed rhomboideus major, rhomboideus minor, and the levator scapulae. And what that does is it exposes these deeper muscles of the back, which are going to be important for posture. So again, this is just to show you how many layers are actually in your body, and this is true all over, not just in your back. Let's talk about carpal tunnel. So you're looking at the right upper limb of a human cadaver, and if we focus on these muscles in the form, you're going to notice that the muscle tissue starts to become tendinous, but as soon as it gets down to the wrist, it runs into this kind of stoppage here, and that's because there is a bunch of connective tissue binding the tendons down called the flexor retinaculum. And that you can think of as the roof of the carpal tunnel. You see, if we were to cut these tendons, you would see an actual anatomical space tunneling through the wrist that we call the carpal tunnel. Everyone has a carpal tunnel. Inside of it are 9 tendons and then 1 nerve called the median nerve. Carpal tunnel syndrome, however, is when you experience inflammation and pain in this space. So this bone right here is called the os coxa, or your hip bone, but I want you to focus on this ridge line right here. This is called the iliac crest, and you can feel this on yourself. If you kind of dig your hand into your side, it's not going to be the most comfortable, but you can pretty much rest your hand on top of this iliac crest. Now, this iliac crest serves as an attachment site for muscles and ligaments, like your gluteus maximus comes up here, and so does the latissimus dorsi, kind of attaches onto it, and so do the obliques or those core muscles on the side. Your eyeball is an outgrowth of the brain, so if I rotate this to the underside, we can see this little projection here. This is called the optic nerve. Now, what would happen is this would continue on and then flare out into this photoreceptive piece of tissue called the retina. And then that retina is then surrounded in connective tissue filled with fluid and has little magnifying lenses in there, which we call the eyeball. So your eyeball literally grew out from the brain, captures light, sends that signal all through the optic nerve, which is then going to travel all the way back here into your occipital lobe, meaning that the eyeball is just an outgrowth. It's a means of capturing light and sending that information to the occipital lobe to be processed. When we're talking about joint stability, there are 2 big terms to really understand called close and loose packed. So I know there's metal here, but I want you to pretend that metal isn't there, and as much of the femur is touching as much of the tibia as possible. That position would mean that the knee is kind of locked like this, is called the close packed position. And that's an extremely stable position. Now, if I start to flex the knee joint, you see that less of the tibia is touching less of the femur. All of this is called a loose packed position. So that is a very unstable position. So you might be asking yourself, well, are there trade-offs? Yes. See, in a closed packed position, when as much of one surface of the joint is touching as much of the other, this is extremely prone to injury. If I came in and hit it from the side, I could easily break ligaments or rupture tendons. But if I'm in that loose packed position, I'm less prone to injury. So it just comes down to stability versus prone to injury. So I want you to look extremely closely to where these 2 vertebrae are touching each other. You see this connection point? That's called a facet joint. There's another facet joint here and here. In fact, you are riddled with all these facet joints between the 2 vertebrae connecting. But I want you to know that the shape of the facet joint really matters. So if we come down here to the lumbar region, we can see that these facet joints are kind of lined up side by side. And what this allows for is when these 2 vertebrae are going to move against one another, they're going to move forward forward and backward. We call that flexion and extension of the lumbar spine. But if we come up, you can see that these facet joints are more oriented anterior and posterior, or front to back. And what that means is it allows your thoracic region to do lateral flexion. And then if we come all the way up here to the neck, you can see that these facet joints are more oriented in the superior and inferior direction, which makes it so your neck can do rotations. Okay, so you see this socket right here that the head of the femur plugs into? This is called the acetabulum, which translates in Latin to vinegar cup, which means that some early anatomists thought that this bony landmark here reminded them of the cup of vinegar that they dipped their bread into, which is kind of strange if you think about it.